at Vermont Oxford Network, and I'm joined today in moderating with Professor Roger Saul, who's the H. Wallace Professor of Neonatology at University of Vermont, coordinating editor of Cochrane Neonatal, and the director of Vaughan's Institute for Evidence-Based Practice. We're thrilled to have a guest discussant with us today, Elizabeth Rogers, who is Professor of Pediatrics at UCSF School of Medicine and Director of the Roots Small Baby Program in the Intensive Care Nursery at UCSF Mission Bay. Today's session is sponsored by Vermont Oxford Network and our Institute for Evidence-Based Practice. Here are our disclosures related to the talk for today, where we don't have any commercial financial issues to disclose. So we hope today is going to be a very engaging session with a lot of audience participation. We have two different ways that we hope to engage the audience today. The first is the chat feature here in Zoom, where we hope that you can chat in questions and comments, and please make sure you send those to everyone so we can engage in a great group dialogue. We also hope to come back to some of those topics in our discussion session at the end of this hour. We'll also have 4 different polls during today's session, and there are a few different ways that you can respond to those polls. We're using the Poll Everywhere platform, and if you have that app, you can use it after you put in the username VT Oxford. If you use this QR code, you'll be taken to the website, and you can answer the questions strictly from the website, or there's an option to send text messages to the number 22333 by texting VT Oxford to that number. So to give that some practice, we're going to start off with our first poll question related to today's talk. So we have an audience now over 600, and we know some are individuals and some are teams all joining together. So answer on behalf of you or everyone in the room with you. And our first question is whether you have written guidelines that address the use of therapeutic hypothermia in infants with hypoxic-ischemic encephalopathy. So the answers we have here that you can choose from are either yes, no, or uncertain if that's a guideline that is used by everyone in your unit. Looks like those numbers are quickly escalating, so we're happy to see that everyone is able to participate. And not surprising, I think based on the audience we have here joining us today, the vast majority already have written guidelines, more than 90% focused on HIE. So thank you for participating, and we are going to move on to our evidence review. And I'd like to introduce Dr. Roger Saul to do an evidence review for us. Over to you, Roger.
Thanks, Danielle. Today, we're going to talk about the translation of evidence to practice regarding therapeutic hypothermia for infants with hypoxic-ischemic encephalopathy. According to the World Health Organization, hypoxic-ischemic encephalopathy is the 5th leading cause of death worldwide for children under 5 years of age. The rates of HIE vary depending on settings, from as few as 1 to as many as 6 per 1,000 live term births. And 15 to 20% of affected infants will die during the newborn period, and a quarter of them are left with permanent neurological sequelae. We have an understanding of the mechanisms of brain injury in these term infants who experience an ischemic injury. There's the initial injury, in which there is necrosis, followed by a reperfusion phase, which has a period of inflammation and cell death, and eventually repair. We know that there is a fairly tight window between the injury and the immediate necrosis and the time at which the secondary effects take place, leaving us a window of opportunity to consider interventions like therapeutic hypothermia. In animal models, there's a great deal of promise regarding hypothermia. We find that mild hypothermia, that is cooling to 32 or 34 degrees centigrade, is neuroprotective, and that brain cooling should be initiated as early as feasible within that window I just described, preferably within 2 hours. And it probably, at least in animal models, should not be continued after 48 or 72 hours. Here's some work from Alistair Gunn and colleagues showing the striking decrease in neuronal loss associated with the institution of therapeutic hypothermia in an animal model. But what do we know from trials in the newborn regarding therapeutic hypothermia? First, I think we have to recognize that the subset of infants who have been enrolled in studies is a very specific group of infants. The participants are highly selected with evidence of peripartum asphyxia, APGAR scores of less than 5 or less at 10 minutes, need for mechanical ventilation or resuscitation at 10 minutes, low cord pH, and evidence of encephalopathy according to Sarnat staging. The criteria for most of the trials have been modified by Sarnat and Sarnat, and some were assessed with AEEG as well. When we take a look at the Sarnat staging, we recognize, one, that it wasn't actually really meant for infants in this narrow window, and two, it takes a fair degree of training to fully understand exactly how to categorize all of the infants, with evaluations of the level of consciousness, spontaneous activity, posture, tone, primitive reflexes, and the autonomic nervous system. One of the goals as we institute therapeutic hypothermia is to make sure that in all settings that babies are born, the staff is capable of making these accurate assessments. What type of cooling has been tested? Well, there are three main approaches that have been used. Initially, many of the trials used head cooling with temperature servo control. A large majority of the trials done in high-income countries have used whole body cooling, also with servo control. But many in low and middle income countries have looked at phase-changing materials without temperature servo control. Here's a picture from the work of Glutman and colleagues looking at an infant who is receiving selective head cooling. Here, from Shankaran and colleagues, is a picture of a baby receiving whole body cooling during the NICHD trial. The infant is placed on a cooling blanket, but also you'll note that they suspended an adult-sized blanket to allow for less variation in temperature and to allow for a smoother process of cooling. In the UK, the Toby trial used a simpler method of direct whole body cooling. Trials like the ICE trial used phase-changing materials to cool babies. They achieved hypothermia first by turning off the ambient heating systems, and then by applying hot-cold gel packs around the infant's head and over the chest to reduce the rectal temperature to 33 to 34 degrees centigrade. Jacobs and colleagues did the original review of these trials back in 2007 and showed us some very striking results regarding the effects of therapeutic hypothermia. In this original review, there are 11 trials involving just shy of 1,500 infants. In this forest plot, we could see that the trials of selective head cooling are shown on top and the trials of whole body cooling below. A total of 11 trials are represented, and overall, whether you use selective head cooling or whole body cooling, there is a meaningful reduction on death. The relative risk is 0.75, so a 25% reduction in the risk. The risk difference, the point estimate, is minus 0.09, with a confidence interval of minus 13% to minus 4%. This gives us a number needed to benefit of 11, ranging from as few as 8 infants to as many as 25 infants to prevent one death. This is a very strong result for any intervention. When we look at the impact on survivors on disability, we also see overall improvements. Fewer trials reported on neurodevelopmental outcomes, but we can see that whether we use selective head cooling or whole body cooling, Overall, there was a significant reduction in disability, a relative risk reduction of 23%, a risk difference of minus 13%, suggesting a number needed to benefit of 8 infants to prevent 1 case of major disability. When we look at the composite outcome of death or major disability, we probably get our best picture of how effective these therapies are. The relative risk reduction of death or major disability is 25%, with a risk difference of minus 15%, suggesting that as few as 7 infants need to be treated to have 1 more survivor without a major disability. These are strong results. They rather quickly led to recommendations from ILCOR and others that adoption of therapeutic hypothermia for selected infants was appropriate. They noted that because HI is a relatively uncommon condition, it would be desirable to centralize this treatment to larger intensive care units. And with the data presently available, they felt there was no longer any reasonable justification to deny this efficacious treatment for those who most urgently need it. But it's easy to write a recommendation based on the efficacy shown in trials, but harder to decide of how we're really going to introduce this in our practice. When we speak of efficacy, specifically, we're talking about the benefit of using an intervention for a particular problem under ideal conditions, a laboratory setting, or in this case, the setting of randomized controlled trials. Effectiveness is the extent to which the specific intervention does what's intended to do in a defined population when we begin to practice it at the bedside. And efficiency is the extent to which the objectives are achieved using the minimal resources. So in our case, we know that mild hypothermia is efficacious. It's a highly promising therapy in the highly selected population of infants with moderate to severe hypoxic-ischemic encephalopathy when treated in a very narrow window before 6 hours of age. But the questions of effectiveness are what of greatest interest right now. Does therapeutic hypothermia work in the most affected infants? Does it provide benefit to less severely affected infants? Does it work outside the restricted time window predicted by animal models and tested in clinical trials? Does selective or whole body hypothermia work best? And what is the role of the use of phase-changing materials in delivering therapeutic hypothermia? And what is the relationship of hypothermia to other therapeutic interventions that we've always considered in this population, such as anticonvulsant therapy? It's a headache. There's a lot for us to figure out. So what are we supposed to do? Let's take a look at some of these questions of effectiveness and see what the literature tells us. So the question that I'll first pose is, what about later? What about treating outside of the time limit that was predicted in animal models and used in the clinical studies? Well, we do have information from Laptuk and colleagues regarding the effect of therapeutic hypothermia initiated after 6 hours of age in infants with hypoxic-ischemic encephalopathy. They did a randomized controlled trial in infants 36 weeks or later gestational age with moderate to severe hypoxic-ischemic encephalopathy and purposely enrolled infants outside of the traditional window, so between 6 and 24 hours of age. 21 centers in the U.S. Neonatal Research Network participated. The results were that for the primary outcome, 19 of 78 hypothermic infants, 24.4%, versus 27.9% of non-cooled infants, had the primary outcome of death or moderate to severe disability. So no difference when they instituted therapy later. A huge disappointment given how difficult it is to identify infants in that tight time window. One of the questions has been whether or not in other settings where in fact hypoxic ischemic encephalopathy may be a bigger burden on the newborn population, whether in these settings therapeutic hypothermia can work. One of the questions that, for example, ILCOR, the International Liaison Committee on Resuscitation, posed that given the fact that therapeutic hypothermia is now standard of care in high-income countries, what about efficacy in low-resource settings and low- and middle-income countries? Well, there is one trial that I think surprised us all, disappointed us all, in terms of the impactfulness of therapeutic hypothermia in these settings. The very well-conducted and well-conceived HELIX trial is a randomized controlled trial of therapeutic hypothermia in India, Sri Lanka, and Bangladesh. Similar to the trials done in high-income settings, they enrolled late preterm or term infants, and they were allocated to very traditional whole-body hypothermia using servo-controlled cooling devices or to usual care. The primary outcome, like in the larger studies done in high-income countries, was death or moderate to severe disability. 408 eligible infants were assigned. 50% of the infants in the hypothermia group and 47% infants in the control group died or had moderate or severe hypothermia, a relative risk increase of 1.06. The interpretation of this work is that therapeutic hypothermia did not reduce the combined outcome of death or disability at 18 months. Therapeutic hypothermia, in their opinion, should not be offered as a treatment for neonatal encephalopathy in low-income and middle-income countries, even when tertiary neonatal intensive care facilities are available. This, of course, set up a huge debate around whether or not this study, in fact, suggests such a cautious approach to therapeutic hypothermia. For one thing, it's impossible to criticize the study for how well it was in terms of introducing hypothermia. Here are the curves from the HELIX trial, looking at the cooled babies and the hypothermic babies. And I pretty much promise you, you could superimpose these curves on the work done at the NICHD or other trials in high-income countries and see that, in fact, they adequately cooled the population. So the intervention was delivered appropriately to these babies. So what is the issue? How does this fit with the world literature? Well, when we make an effort to try to update the classic review of cooling, we find many new trials, many of which were done in low or middle income countries. We now have 29 trials involving 3,435 infants. This is a very busy graph that is showing all the current trials available and looking at the effect on death. And it includes the trials from the high-income countries, which are noted on the top of the graph here, and the trials that were conducted in low and middle-income countries in the bottom part of the forest plot, as well as the typical estimate. Based on this unrestricted analysis, the results of cooling in both high-income countries and low and middle-income countries are in fact very strong. From this data, it appears that the impact on death, despite the inclusion of the HELIX data, has a real benefit. When we look at this unrestricted examination, we see the results of death being important both in high and low and middle income countries. But there's a catch when we look at the data more closely. It's fairly rare as you read a meta-analysis that you pay attention to the funnel plot. It's a plot that you look at the scatter when you plot the standard error versus the log odds ratio. It is supposed to be symmetrical if there are no biases introduced by the included studies. But it may be asymmetrical if publication bias is present or other unmeasured sources of bias. When we look at the attempts to update the reviews to include these trials done in low and middle income countries, particularly with phase-changing material, we see severe asymmetry in these studies, suggesting that there are biases that we do not understand that are influencing this result and calling these results into question, leaving us wondering whether or not we know as yet how best to introduce therapeutic hypothermia in low and middle income countries. I would argue that it's more of an issue of how we select the patients who may benefit, especially given the fact that we know that the Helix trial did the intervention appropriately, but may or may not have enrolled the babies who would most benefit. And I think more work needs to be done to understand this. The recent ILCOR recommendations do recommend therapeutic hypothermia in low-middle countries, provided that they can provide high-level care in their NICUs. So then there's the question of whether or not we've got it right. Do we have the time frame right for how long we cool babies? Do we have the temperature right about how deeply do we cool these infants? And I like to think of this as the chicken soup theory. There's my dear grandmother Rose on the left, and she had a basic theory about health and wellness. If a little is good, more is better. So let's take a look whether or not Grandma Rose's opinion holds true when it comes to therapeutic hypothermia. Shankaran and colleagues did a study looking at the depth and duration of cooling on deaths in the NICU amongst infants with hypoxic-ischemic encephalopathy. Their objective was to determine if longer durations of cooling, 120 hours as opposed to the traditional 72 hours, and deeper cooling down to 32 degrees centigrade are superior to the traditional approaches. Infants were assigned to 4 hypothermia groups that combined the deeper and longer arms of the study, and they looked at the primary outcome of death or disability. The trial was closed for safety reasons and concerns regarding this approach. And here's the data. When it comes to the depth of cooling, and we take a look at death, we see that there's an increased rate of mortality, 14% versus 7%, in the infants who were cooled to lower temperatures. And there is no difference in death regarding infants who were cooled for longer or shorter durations. So let's get to perhaps the question that people have the most interest in, and that is, can we cool infants with less severe signs of hypoxic-ischemic encephalopathy? The data from the trials don't help us all that much. There are very few trials done in infants with mild encephalopathy. And as you can see from the top of this forest plot, in those occasional trials, there is really no reliable estimate. For the trials done with infants in moderate encephalopathy and infants with severe encephalopathy, you can see that the results of cooling are probably strongest in the infants with moderate encephalopathy and somewhat attenuated in infants with severe encephalopathy, but nevertheless effective in both populations. So many authors have asked the question about whether or not we should be offering therapeutic hypothermia to babies with milder signs of neonatal encephalopathy. And here is an editorial from Eldib and colleagues that address that issue. They note that there are several key questions that need to be answered. First of all is whether we can define neonatal encephalopathy in the first 6 hours after birth so as to distinguish between other brain injuries and mild encephalopathy. And second, of course, is whether or not cooling infants with mild encephalopathy will improve or worsen neurological outcome. Conway and colleagues report a systematic review of the long-term developmental outcomes in infants with mild hypoxic-ischemic encephalopathy. For the purposes of this study, they defined an abnormal outcome as death, cerebral palsy, or a standardized neurodevelopmental test score more than 1 standard deviation below the mean. They found abnormal outcomes in a quarter of the infants with mild hypoxic encephalopathy, raising genuine concerns that this is a population that could potentially benefit from therapeutic hypothermia. So what is current practice? Erica Edwards has provided us this data from NICU by the numbers, showing that in fact there is an increase in the use of therapeutic hypothermia between 2012 and 2021. We reported a rate that went from 0.9% in 2012 to 1.5% in 2021. In addition, more infants who are below the usual cut point of 36 weeks gestational age are being treated, with close to 7% of the infants who receive therapeutic hypothermia being preterm. This is, of course, terra incognito. These infants have not been studied adequately. A national survey of practice in the UK tells us that a great deal of cooling is being instituted in infants who have mild signs of HIE. In this survey from 74 neonatal units, they received responses from 54 units and noted that of these centers, 75% offered cooling to infants with mild encephalopathy. The reasons for considering it, there are pros and cons. For the units offering cooling therapy, they addressed issues such as the risk of long-term adverse neurological problems, the difficulty of grading neonatal encephalopathy soon after birth, that we've all had the experience of seeing infants who we thought had mild encephalopathy, but then appear to evolve worsening symptoms over the first several hours of life. There was concern about the idea that families would feel that this was negligent and that litigation might ensue. And that in general, they thought that cooling therapy was safe and easy to provide. For those infants not offering cooling to infants with mild encephalopathy, they thought, well, the vast majority do well and do not go on to have neurological deficit. In particular, the vast majority do not die, and so we're only dealing with the somewhat smaller benefits that have been reported in the more severely ill infants vis-a-vis developmental outcomes. There is no clinical evidence to support cooling in babies with mild encephalopathy, as we've seen. And that cooling therapy is not without side effects, particularly having PPHN and thrombocytopenia reported in many of the clinical trials. And that they want to avoid additional interventions and prolonged hospitalization. Our colleagues in California have reported the trends of the use of hypothermia and the opportunities for improvement. They identified close to 63,000 infants greater than or equal to 36 weeks gestation in the California Perinatal Quality Care Collaborative between 2010 and 2019. What they saw in terms of the rates of HIE and the rates of cooling was that there was overall an increase in the rates of HIE, perhaps due to increased case finding, but also increasing use of therapeutic hypothermia in infants with mild HIE. To try to address this divergence in practice, where there are many who are saying that we really can't afford not to offer cooling to infants with milder encephalopathy, the group doing the PRIME study has set out to look at these infants who are, in fact, getting HIE, getting cooling. They wanted to determine the short-term outcomes of infants with hypoxic-ischemic encephalopathy at birth, and then as a further study, evaluate those infants who wound up being cooled. They did, in the first phase of their study, find a larger than expected proportion of infants with mild HIE who had abnormal outcomes. They are now on to a phase of enrolling infants either at centers that have routinely decided to give cooling therapy to infants with mild HIE versus those that have not. And this is a reasonable approach if, in fact, you feel that you cannot stand back and not offer cooling therapy to this group of infants. That said, there is a very reasonable view that says that there's costs and perils to therapeutic creep. This in an article by Kumar and colleagues, who suggest that, in fact, until there is further evidence from adequately powered randomized controlled trials, cooling in mild encephalopathy should be considered experimental, and parents should be consented before providing this therapy. Many people have argued that it would be impossible at this stage to conduct randomized controlled trials. But that's clearly not true. There are pilot randomized controlled trials that have been conducted in this exact population. In this study from Montaldo and colleagues, they randomized infants to whole body hypothermia versus targeted normothermia in infants with neonatal encephalopathy. In this study, a relatively small study involving a little over 100 infants, the infants were randomized either to normothermia, hypothermia for 48 hours, or hypothermia for 72 hours. And although they only looked at surrogate markers in terms of MRI findings, they found no differences in the groups, suggesting that one, there's no obvious effect of cooling, and two, we need more clinical trials to address this issue. I'll be very curious in our discussion, especially when we hear from the parents, about how they interpret this data and how they think we should proceed. But I will end with a fortune cookie that I literally got when I went down to the first guideline development conference on therapeutic hypothermia. The world belongs to the enthusiast who keeps cool. And I would suggest that we still have a ways to go to develop the important evidence to understand how best to use this therapy. So let's move on to the discussion and discuss where the evidence takes us, who needs to be cooled, what we think are the best practices in terms of optimizing, and what future research is needed. So I'll turn it back to you, Danielle. Thanks.
Thank you so much, Roger. That was an incredible evidence review on a very important topic worldwide. As a clinician, I know this topic is still giving us headaches, who to cool, and sometimes I think the more difficult question, who not to cool. So as we think about translating evidence to practice from those highly selected patients, oftentimes with complete information and strict or ideal conditions of a randomized controlled trial, to the variety of patients that were presented to in front of us, and the clinical challenges when we really try our very best to use the evidence and to think about the patients and families and providing the best possible care. I'd like to engage our audience with 3 cases that I think will prompt some rich discussion as we then invite Dr. Rogers to the podium afterwards. So we'll have 3 cases, and these again will be with the Full Everywhere platform. Unfortunately, the chat box cannot get tabulated. So if you can use the QR code, the app, or that text message that you can see at the bottom there, that's how the answers can be collected together. So the very first case, these are all clinical cases. So you're called to see a 4-hour-old, 35-week gestational age newborn with a history of cord prolapse, severe acidosis on umbilical gas with a pH of less than 7, an APGAR score of 3 at 5 minutes and 5 at 10 minutes, who has lethargy, decreased spontaneous activity, and hypotonia. So on your astute physical exam, you're rating this as moderate encephalopathy. So I think that the key here is this patient is a 35-week gestational age infant. So in your practice, would you recommend starting therapeutic hypothermia for this particular patient? It looks like out of our audience of more than 900 now, we're having close to 200. The polls are coming in quickly, but it looks like, Liz, we see the majority, more than 3/4 of people who are responding thinking that they would start therapeutic hypothermia for this 35-week infant baby. So we'll keep that in mind as we think about this evidence to practice. I'll give it just a few more seconds, but it looks like our stats are holding pretty steady, around 75 to 80%. All right, so that was the late preterm infant. The next case we'll move to is you're called by a referring physician. I know many of us are in regional transfer centers, and this is our day-to-day job. You're called by a referring physician for an 8-hour-old, 40-week gestational age newborn with a history of shoulder dystocia, severe acidosis on an umbilical blood sample, same pH less than 7, same APGAR scores, 3 at 5 minutes, 5 at 10 minutes, who has lethargy, decreased spontaneous activity, and hypotonia. Again, a moderate encephalopathy on your exam. So this infant term and is meeting criteria, but is slightly older outside of that 6-hour window at 8 hours of age when you're receiving this call. So thinking about applying the evidence to this patient, looks like only about a third of our audience is considering cooling for this patient who is outside of that 6-hour window at the 8-hour time point. Interesting. It looks like we have a great response. So thanks for everyone joining in who is participating. So about a third cooling for the late to presentation infant. All right, and then the last clinical challenge we have coming up is a 5-hour-old, 40 weeks, so term infant. Similar presentation, severe acidosis, umbilical gas less than 7, APGAR scores 3 at 5 minutes, 5 at 10 minutes. However, this patient's physical exam, the patient to be hyperalert, jittery, inconsolable, an exaggerated response to stimuli. So this patient has mild encephalopathy based on SARNAT staging. And this looks like about a 50-50. So about 50% of our audience, and we're now about 200 respondents, saying that they would recommend starting therapeutic hypothermia for the patient who is presenting with mild encephalopathy and otherwise the clinical history and the laboratory findings that meet criteria. Very interesting. So thank you very much to our audience for walking through 3 different case presentations, I think that are representative of patients and situations that we're challenged with on a day-to-day basis, all wanting to do the best with the information that we know from the literature and applying that to the patient in front of us. So I think with those clinical conundrums in mind and the audience polling results, as we think about translating evidence to practice at the bedside, I'd like to welcome our guest discussant, Professor Liz Rogers, to the mic.
Thanks so much, Danielle, and the whole team at Vaughan for the opportunity to join you all today. And I think therapeutic hypothermia has been such a major breakthrough for the treatment of hypoxic ischemic brain injury of the newborn that many of us clinicians at the bedside have seen evolve and become standard practice in our lifetimes. So to our trainees and our early career colleagues, it's hard to over-exaggerate the impact of a therapy that literally meant we went from having nothing to offer to having something significant to offer an infant and their family in a critically vulnerable window for potential lifelong impact. And it's hard to quell that enthusiasm and to keep it contained when we start getting into gray areas. But refining a therapy to make sure it is having all the positive impact it possibly can without causing harm and its overuse could be the essential story of neonatology. And that is some of what we are all navigating now at the bedside. So ensuring all who will benefit are identified early and get to where they can receive the care is paramount, while also not transferring or separating babies from their families when they won't benefit. In our Vaughan Quality Improvement Collaboratives over the last several years under the umbrella theme of all care is brain care, several of our centers have focused on streamlining processes of identifying infants who would benefit from therapeutic hypothermia, establishing protocols for initiation and for monitoring, such as through amplitude integrated EEG and various imaging modalities. But even with standardizing protocols, the cases just presented show that we all have to make decisions in gray areas. When a baby is a day younger than the trials studied, or whose pH is 0.01 higher than the trials cutoff. And we have to make a quick weighing of risk and benefit to employ a therapy that's super time critical. We've learned from the excellent work of Monica Lemon, Linda Frank, and Betsy Pilon, and others about the impact of therapeutic hypothermia on families. And I love that Roger referred to that. And we must work to mitigate the potential harms of the therapy we're employing, such as through good communication, parental and family partnerships, allowing holding and feeding wherever possible during hypothermia, and follow through in the transition to home and community support and services. So optimizing therapeutic hypothermia, making those decisions in the gray areas, to me, is dependent on a circuit or a network of relationships. The relationship between obstetric and pediatric services, between the bedside nurse and the medical provider, between referral and regional centers, between the neonatology and the neonatal neurology teams, and between all of these folks and the family at the center. Standardizing the when and how and the what to communicate in all these relationships, I think will help ensure the right infants receive the therapy they need. So these relationships, just like protocols and guidelines, are great targets and opportunities for quality improvement efforts. And I think maybe the real needle movers. So I'm happy to talk more about my bedside experiences and represent the All Cares, Brain Care, and other Vaughan centers who have engaged in work in this area over the years, as we open up now for discussion.
Thank you so much, Liz. And I see a lot of comments and chat questions coming in. I have a few that maybe we could start with. And I think first, recognizing the amazing work that's going on in the community with the All Carers Brain Care Collaborative and many teams within that focusing on best practices or potentially better practices for evaluating and treating infants who have hypoxic ischemic encephalopathy. You mentioned a few of those, such as the integration of AEEG, thoughts about for the many teams and team members who are joining in today who haven't been part of that work. If you have a few nuggets of things that you've heard teams doing, especially as they help to adjust the trial protocols to what their unit's guideline is going to be, and putting in some potentially better practices for their unit and standardizing care. Any tips for things that are trying to bridge that trial to then local guideline and refining those local guidelines over time as new technology has become available?
Yes, I think one major target, and you, Roger, again, you mentioned some of the work done in California, and through the California Perinatal Quality Care Collaborative, there's been a lot of work, particularly around identifying and infant transfer to regional centers who are capable of providing kind of the holistic care that therapeutic hypothermia requires. And I think that identification and really engaging the right people to do that identification, working with obstetric services, working with bedside L&D nurses, as well as neonatal nurses, to really call attention to medical staff who might be the one to actually make the call, but working on referral call standards that might be slightly overly broad, or again, go outside of what the trial indicated, but to ensure then that the consult is made and that the call is made, so that if an infant is identified who would benefit, then the transfer of care to a center that's capable of providing the therapy is quite efficient. So that's been one target for us. I think the other target is when, after making the decision about therapeutic hypothermia, how to really include families as partners in a very, very challenging time of necessary separation, whether between hospitals, if an infant has required therapeutic transfer, or even within birth units or the units of care in the United States, where our units of care are quite separate. And I know I see some comments coming in about holding and the potential for kangaroo care. I would say in the US, we don't provide kangaroo care during cooling, but we do absolutely recommend holding whenever appropriate on the cooling blanket. So not standard kangaroo care necessarily, but providing therapeutic touch wherever we can between a family and their infant. And we can talk about more, but those are areas that we've seen folks make quite a bit of improvement utilizing, QI methodology and monitoring their metrics.
Ron Kleinman makes a point that is dear to my heart, which translating the animal evidence to the clinical trials and then to practice. We have failed in animal models with any number of therapeutic agents because we know when we insult the animal and we know when we can give the drug, whereas in our clinical context, we have no real sense except when there really is a specific incident right in and around labor and delivery. And so anytime we're expanding time frames of when we're going to identify patients, when we're going to cool patients. It's fraught with difficulty, and I personally believe that those are some of the issues that probably influence the results of the HELIX trial. One question that keeps coming up, guys, is the role of AEEG, which I did not discuss. Is that commonly used in your practice, Liz? Does it, in anyone's mind, add to our ability to differentiate the more mildly affected child clinically?
So we certainly know that amplitude integrated EEG or AEEG was utilized in many of the trials as criteria for inclusion in the trial, as a metric of potential severity of injury or potential for injury. And I think that as more information has become clear, as we've translated this to the bedside, we know that there are multiple uses for both amplitude integrated EEG or full montage EEG, as well as other, I think, neural monitoring such as NIRS and others. But in our center, we still monitor both with amplitude integrated and full montage EEG because the goals of them are different. We know there is a significant risk of seizure, and we know that the amplitude integrated EEG is a tool that we as neonatologists who aren't neurophysiologists or epileptologists can really interpret much more readily at the bedside and on a minute-to-minute basis. In fact, our neurointensive care teams, in particular, our bedside nurses, have become experts at interpreting the AEEG. And so the bedside nurses are seeing the spike in amplitude, and they're immediately calling us and saying, I'm seeing what I think is an evolving seizure. Well, that's not something we can get even from a neurophysiologist sort of at home monitoring all the time to get such real-time data so that we can quickly treat seizures when identified. And that we know is critical through the National Seizure Registry and other studies. So I think there is absolutely a role for amplitude integrated EEG. But certainly the full montage, whenever capable, gives us a much broader swath of information around areas of potential injury, about the seminal, the specifics around seizures. So I really do think in partnership, both are very useful tools, but serving different goals.
Thanks, Liz. I was really struck with the number of participants who would cool that preterm infant. And equally struck by the number who have equipoise regarding the mild kid. But let me just throw out that preterm infant. One, were you guys surprised? And two, I mean, and I can add to this, what do we really know about the preterm?
I was very surprised by that one. That was the biggest poll that surprised me, only having about 20 up to 25 maybe percent saying that they wouldn't cool a 35-week infant when, for the first 15 years of providing this therapy standardly, we absolutely would not have cooled less than 36 weeks. And most of our guidelines still say less than 36 weeks is a contraindication in terms of guidelines I have reviewed. So I do think there is, like any gestational age estimate, my area is often thinking about a different gestational age, 22, 23, 24. But like we know, many 35-weekers are actually 36-weekers. And unfortunately, some 35-weekers are actually 34-weekers, where we know there's a potential or we think there's a greater potential for harm in employing the therapy. So I do think that 35-week window is still a little bit controversial, more controversial than our poll showed. But I think you do have to take and assess maturity in other ways when you meet that infant, and also obviously parental involvement in sharing what the trials have shown us and what the potential benefits still may be.
Yeah, Liz, I'm with you. I was a little surprised in my own personal review of the literature. It doesn't come from formal trials, mostly from retrospective reviews of places where they have cooled babies. And I threw a few of those references into the chat. They sort of give us a different message. One says that when they look at babies who were term and were cooled and babies who were preterm were cooled, that they're much worse outcomes in the preterms. But the preterms are more fraught with difficulty in either case. And one other small experience says of the preterms we cooled or didn't cool, the cooled ones did about the same. They had their share of complications. So I'm left, again, not knowing that there's any positive effect and being cautious like you, Liz, when it comes to that issue.
Yeah, I feel similarly, Roger. And I think, Liz, I was also surprised by that. And I think, just as you mentioned, when we're outside of especially our hospital guideline, which oftentimes will have that 36-week mark, how important it is for shared decision-making with families. I had a question, Roger. I saw it come up in the chat. In addition to the gestational age, the birth weight. So in the original trials, 1,800 grams being that lower cutoff. But when we know it is a term infant, we have early ultrasound or, really trustworthy data that we think we're above that 36-week cutoff. But there is growth restriction. The baby is SGA and they're 1,750. Do we have equipoise in that, or do we have evidence to think that there is additional harm from the birth weight perspective? Any thoughts from either of you on that clinical conundrum?
I hadn't thought about that a lot when I was sifting through the evidence and preparing. I didn't even think of it as a poll question, but I did see it come up in chat. I guess there are two issues there, Danielle. One is our whole sense of the smaller babies and their thermal control, right? Mm-hmm. And just how they're going to maintain thermal control. We always worry about that whole surface area, heat loss, and damage and injury. But I think the other question is, why are they small? Why are they growth restricted? Is there a chronic process that might involve brain development, and might I exacerbate it with cooling? And might not that be part of the helix experience again? All speculation. So I'd be loath to cool the extremely growth restricted infant, though in my mind I don't have necessarily a strict weight cutoff. Liz, I'm curious.
Yeah, no, I agree. I completely agree with how you're thinking about it, Roger. And I think, when you think about growth restriction and you think about the infant who's going to benefit the most from hypothermia, it's typically the infant who's undergone a sentinel event, as you reviewed, a uterine rupture, placental abruption, et cetera. But if there is some hypoxic injury from a chronic process that might be also reflected in their IUGR status, or that caused stress during the birth process, which then led to identification of an infant, like they're just not going to benefit in the same way as an infant who had an acute insult. So there are some things to tease out, but I think I hadn't thought about it as much as I probably should have. But I think for an infant who we know is 36 weeks and is just small and has a sentinel event, I would take that into account, and I wouldn't want to withhold therapy just because of birth weight alone.
Liz, you talked a lot about communication with the families. There's also communication with the referring hospital and the referring physicians. And I briefly put up the SARNAT scoring when we were going through the evidence. It's not straightforward. And the need for physicians as old as I am to identify it early is not necessarily in the forefront of our mind. Before there was cooling, we watched these kids. We didn't score them in the first hours of life. What has gone on in Vermont or in California about educating the referring physicians and hospitals about identification of these infants and better learning around what is HIE in the newborn?
Well, it's perfect timing because Dr. Jochen Profit just put into the chat our California early screening and identification of candidates for therapeutic hypothermia toolkit. So I will definitely refer to that, but there's certainly, I think this is a great target for work done in regional areas to really think about how to refer, and then obviously making those referral relationships really strong. Certainly, we know at the bedside, we do get the calls of like, well, do you know this person in the community? Could their neuro exam? What do we think their neuro exam capacity is? How many babies do they see? And the truth is, relationships tend to settle all of those concerns. And when you say, oh, well, I know, I did an outreach conference there and I spoke with that provider. We went over the toolkit, and I am grateful and trust that they are calling me because they're concerned. So I do think relationship-based approaches to this certainly then decrease the barriers to then have those folks reach out. So I encourage people to look at the toolkit from California.
Great, thanks, Liz. And Roger, I think similar in the Northern New England area with our perinatal collaborative, there's been a real focus on standardizing care, having guidelines that all of the community hospitals and referral centers are looking at together. So it is expected if a baby presents, with a certain delivery course or cord gases, that there will be a call in communication. One newer thing that I think has been of benefit is to have video assisted telecommunication. And so we are seeing and discussing a patient together. And I would expect, as time marches on, we'll see more and more of that additional ability to see and evaluate a baby together and look at the exam in real time. Yeah. I had maybe a quick question for Liz and then a quick question for Roger, because I know our time is running short. Liz, related to this standardizing care, I know one thing that comes up in my unit all of the time is the dynamic exam. And we had talked about this a bit, of the baby who has a delivery that you're already thinking in your head, will be evaluating this patient to see how they progress. A patient that maybe has a severe encephalopathy exam or moderate in the delivery room, and then by 30 minutes of age is rapidly improving. And I think your focus on standardizing care and how are we as a multidisciplinary and many team members thinking about that in a structured way for every patient so that we're providing fair and equitable care and thinking about this together. Any thoughts on that timeline for those cases that sometimes surprise you by how quickly they improve?
Yes, this certainly has been a conundrum ever since we started utilizing therapeutic hypothermia and this rapidly evolving or changing exam. And we did phone some friends prior to this and spoke with Sonia Bonifacio, who's one of the folks who's really focused on mild encephalopathy specifically, but Lena Chalik and the Cool Prime study are tackling some of this as well, trying to standardize this. And most folks have really said that exam at an hour is really where we want to focus our energy. And for an infant who has rapidly transitioned and looks literally completely normal at an hour, that is very helpful information that you would then take into account with all of your other, standard eligibility criteria as you assess. So I do think that 1 hour time mark has become the standard of practice for most of us as we make our assessments. Certainly, we're concerned earlier. Many of us are monitoring that temperature very closely throughout that time. But for an infant who really does examine completely normally at 1 hour, we take that into account. So I think that being the time point for most of us as we move forward will help standardize as well.
Yeah. Thinking about that, Roger, as we are translating from the evidence to these challenges, one of your slides left us with some burning questions. One of those, which I always love to hear your take on, is what future research is urgently needed? What do you think might help us to solidify our approach or provide improving care moving forward and help us answer some of these tricky questions that we're still struggling with?
That's a tough one because there are two that are at the forefront of my mind, and I think we address them. One is the issue of how does this translate into the low and middle income countries? It's a problem that is so much more prevalent there, so much more death associated with it there. And the conundrum of the Helix trial demands trials that more carefully look at the entry criteria, the need for a sentinel event. I don't know enough about obstetric care in all the various venues that constitute low and middle income countries to understand what a woman knows about her pregnancy and what the caregivers know about it. But we need something that focuses on the patient population, not just the cooling technique per se. So I would love to see that happen in those settings because I fervently believe that if it works in mammalian animal models and we make it work in high income centers, we can make it work in low and mid income centers if we all work together with the caregivers there and the families there to understand who might benefit. So that is very much to my heart and very urgent. And of course, like everyone, I am concerned about this mild child with the 25% poor outcomes. Is there a window to improve there? And I applaud the prime group saying we don't have equipoise, but we're going to continue to push the science. But I do believe that RCTs are possible. I think they've shown to be possible. So those are the two things I would pick on for that.
Thank you, Roger. And I totally agree. I think more information about the right therapy at the right dose for the right patient in the right place at the right time. And I think there's more that we can learn. Thank you. Well, that concludes our hour. But before we wrap up, I want to make sure everyone who has joined us here today has an opportunity to gain some continuing education credit. You have 30 days to fill out this evaluation to get your 1 hour credit from today's session. You can scan the QR code or go to the website listed there. And then this was such a wonderful chat and discussion. I have learned so much. I think everyone who has joined in has learned as well. We hope that you join us again. Our next session is coming up in May, still in this All Care is Brain Care theme, but with a bit of a different focus on the Eat, Sleep, Console approach for our neonates who are exposed to opiates and are exhibiting symptoms of withdrawal. So we hope to see everyone in May. And of course, as we alluded to, we have ongoing work and collaborative quality improvement focused on All Care is Brain Care. So if you have interest in learning more about that, please reach out to the Vaughn team and we'd be happy to explain more. Thank you everyone for joining us and have a wonderful day.